Hello everyone. Today we'll be talking about hypoxemia caused by right to left shunt. So what is a shunt? Here we have two normal well perfused alveoli. If your alveoli becomes non-functional for any reason, your lungs will end up causing hypoxemic vasoconstriction in this area, such as to reduce the perfusion to those alveoli. If that doesn't happen, blood passes through the lungs without getting oxygenated. This is called shunt. It's also called venous admixture. We calculate the shunt using a ratio called shunt fraction, which is the ratio of the blood flow through the shunt divided by total blood flow. So here QT is the total blood flow and QS is the blood flow through the shunt. Around 2% of your shunt is anatomical shunt. There are Thebesian veins in the left ventricle which drain directly into the LV and bypass the lung. This constitutes around 0.3% of the cardiac output. And there are bronchial veins which carry around less than 1% of cardiac output, and they also drain directly into the pulmonary veins. The bronchial veins can carry more amount of blood and hence increase anatomical shunt in diseases like bronchiectasis and pathologies such as coarctation of aorta. Let's understand some of these terminology. QT is the total blood flow. C venous O2 is the oxygen content in the venous blood. C capillary O2 is the oxygen content in the end capillary blood. And C arterial O2 is the content of oxygen in the arterial blood. If you have a shunt, in this case denoted by QS, and it's a pretty small amount of shunt fraction will be this small arrow divided by the big arrow. The big arrow is the QT and the small arrow is the QS. And since the end capillary oxygen content does not mix with anything coming from the QS, because QS is pretty small, the C arterial oxygen would be equal to the C capillary oxygen. Here the shunt fraction is almost 0. If the blood flow through the non-functioning alveoli increases, the oxygen content in the end capillary will be higher than the oxygen content in the arterial side because of the mixing of blood from the venous side, which is not oxygenated, and the shunt fraction is increased. In this case, if 25% of the blood flow goes through the shunted area, the shunt fraction will be 25%. If more blood flow goes through the shunted area, for example in this case 50% of the blood flow, the shunt fraction correspondingly increases and the oxygen content in the arterial side correspondingly decreases as compared to the end capillary. Let's convert all the understanding of the shunt fraction into an equation. So the shunt fraction is QS by QT, which will be equal to the amount of blood flow through the shunt and the total amount of blood flow, that's QT. Now the QS would be equal to the degree of dilution of oxygen contained by the shunt. That means how much of this C arterial O2 was diluted by the venous blood, and that we can easily calculate by subtracting the arterial content from the capillary content. The total QT will be found by the actual increase in arterial oxygen content if there was no shunt. That means the maximum C arterial could ever achieve would be C capillary O2. So we can get the QT by subtracting the C venous from C capillary. The ratio of this would be QS by QT. So let's understand how to derive the shunt fraction equation using the mathematical way. Total amount of flow QT will be equal to the total amount of flow through the capillaries and total amount flowing through the shunt. So you can write QC as QT minus QS. The total content of oxygen in the arterial side will be equal to total blood flow into CaO2, and this will be equal to the total content of oxygen coming from the capillaries, that is QC times CCO2 plus the total amount of oxygen content coming from the shunt, that is QS into CVO2. If you replace the QC in this equation 2 from equation 1, you should be able to get the ratio QS by QT. the oxygen content of the blood is 1.34 multiplied by the percentage SATs multiplied by the hemoglobin concentration, and you also add the dissolved oxygen, that is 0.003 divided by the partial pressure of oxygen. So the oxygen content of arterial blood will be 1.34 into percent arterial SATs multiplied by hemoglobin level plus the dissolved oxygen in the arterial blood, and similar number you can get from the mixed venous blood. You can get your CaO2 from the arterial blood gas, and you can get the CvO2 from the pulmonary artery catheter blood gas. However, the oxygen content in the capillary blood is more difficult to calculate, and here we have to make a few assumptions. It's very difficult to measure the partial pressures of oxygen in the capillaries, but we can assume that the alveolar O2, the partial pressures of the oxygen in the alveoli, would be same as in the capillaries. In the previous lecture, we talked about how oxygen diffuses across the membrane and it equilibrates with the alveolar oxygen in around 0.25 seconds. And we also talked that diffusion across the alveolo-capillary membrane is rarely the reason for hypoxemia. So your P alveolar O2 is equal to the P capillary O2 in most circumstances. The partial pressures of alveolar O2 are easy to calculate. Use this formula where 760 is your atmospheric pressure and you subtract the vapor pressure, which is around 47. And if you multiply that by FiO2 and subtract the amount of carbon dioxide, you should be able to get the partial pressures of oxygen in the alveoli, which will be equal to the partial pressures of oxygen in the capillary. Once you have calculated the P capillary O2, to convert them into SATs, use the Severin-Gauss formula. And once you have calculated the SATs, you can use those numbers to get your oxygen content in the capillary blood. Let's do an example to illustrate this. It's very easy to calculate your equations if you keep your patients on 100% FiO2. So let's keep the patient on 100% FiO2 and check a ABG and a VBG. This patient has hemoglobin of 15. So your P capillary O2 would be equal to P alveolar O2, and that would be 760 minus 47 minus 45. That's the PCO2 from your ABG divided by the respiratory quotient. Here we are assuming it is 0.8, which comes to 657. And partial pressure of 657, the SATs would be 100%. Here you don't even have to use this formula because at PO2 of 657, you already know that you are at the top of the oxygen dissociation curve where the SATs are 100%. So let's put in the values in this formula. Here the capillary oxygen content would be 1.34 multiplied by hemoglobin level multiplied by the FiO2, which is 1, plus 2. This is the dissolved oxygen that you got by 0.003 times 657. This is the oxygen content on the arterial side. Here the SATs are 98%, so you get 0.98. Your dissolved oxygen will be around 0.3. That's your PO2 of 100, and you multiply it by 0.003. Similarly, you get the denominator where your O2 SATs are 75% and your dissolved oxygen is around 0.1. And when you solve this, you get a shunt fraction of 35%. So there are some other ways to calculate shunt fractions which are much easier, though they have more assumptions. One of the assumptions that you can take is an AvO2 content difference of around 4 to 5, and you can take this when you do not have a mixed venous gas available to you. The assumption you are making is the denominator of the shunt equation, which is CCO2 minus CvO2 of around 4 to 5. Let your patient breathe 100% oxygen unless the nitrogen has been washed out, which takes around 20 to 30 minutes. And then you can use this adjacent nomogram to calculate the shunt fraction. Previous case, a PO2 of 100 on 100% FiO2 should give you a shunt fraction of 0.42, that is 42%. You see that the shunt fraction from this nomogram is higher than the one we previously calculated, because our AvO2 content difference was around 6.8. If you don't have a nomogram available, you can use a different way to calculate your shunt fraction. The assumptions here are pretty similar to the previous one, with 5% AvO2 difference and RER of 0.8. Here, for every 100 centimeter of water difference between the alveolar O2 and the arterial O2 gives you 5% shunt. You can calculate the alveolar PaO2 using the equation that we talked about before, and the arterial PaO2 comes from the ABG. So how do you approach this? Well, start your patient on 100% FiO2. Your P alveolar O2 should be around 650. You check the arterial PaO2 from the ABG, say in our case was 100, and you subtract these two numbers. 650 minus 100 gives you 550, and for every 100 difference there is at least 5% shunt. So the shunt fraction is at least 27.5%. It is okay not to be very exact, as the shunt fraction simply tells you how severe the disease is. All you need to figure out is if the shunting is the underlying cause of hypoxemia in your patient, because that does changes some of the management. And sometimes it's important to know if the shunt is cardiac or extracardiac, so calculating shunt fraction can help you with this diagnosis as well. In ICU, you can use a PF ratio less than 200, would suggest a shunt fraction of at least more than 20%. So why does right to left shunt doesn't respond to oxygen? This is your oxygen dissociation curve, and on the x-axis we have got partial pressures of the oxygen, and on the y-axis you have got the how much oxygen is carried by the blood. Here we have a patient breathing 20% oxygen, and some of the blood is going through the normal alveoli while some of the blood is going through the shunted alveoli, and his SATs are 88%. Your P capillary at 20% oxygen would be around 100. That will give you an oxygen content of around 17. Now let's give this patient 100% oxygen. Now your P capillaries are around 600 to 650, and you're at the top of the curve, and you can see that your oxygen carrying capacity has increased slightly from 17 to possibly 18 or 19. There is some increase in oxygen carrying capacity when you give them more oxygen, but that's pretty minimal, and that is coming from the normal alveoli. The shunted alveoli still doesn't count. However, in a lot of the ICU patients, you typically don't start at 20%. These guys are possibly at 50-60% FiO2, and their P capillaries is already around 300. You're already on top of the curve. So increasing your FiO2 from say 60 to 100% is not going to make any difference in oxygen carrying capacity. Think about shunt as a chicken plant waste flowing into the river, and this results in poor water quality. Even if you clean the river, the water quality will remain poor as long as there is stuff coming from the chicken plant. The only way to make your water quality better will be to decrease the shunt. One other interesting thing about shunt is as the shunt fraction increases, the PO2 response to the FiO2 drops. And this is one of the way you can also figure out if the shunt is present or not. In this case, you increase your FiO2 from 0.4 to 0.9 in a patient with 0% shunt, and you can see that the PO2 improves from 250 to around 600. However, a person with 25% shunt, the increase in the PO2 is only from 80 to 120 for the same degree of increase in FiO2. One of the things that you can get confused about is that shunts don't respond to oxygen, but here I am seeing some improvement in the PO2. Shunts still do not respond to oxygen, but there is a small increase in oxygen content due to dissolved oxygen, which is about 2 ml per 100 cc of the blood when you increase your FiO2 in the normal alveoli from 0.2 to 1. If you remember this diagram, your P capillary O2 at 40% in either of the cases is already pretty high, and you are on the flat portion of the oxyhemoglobin dissociation curve. And you can see there's a very slight increase once you go from P cap of 200 to P capillary of 600 when you give 100% oxygen. And this is all because of increase in dissolved oxygen, which comes from the formula 0.003 times arterial PO2. There's another factor that plays into this role, which we call VQ scatter, one which we'll talk about when we talk about ventilation perfusion mismatch.